Welcome to the Johns Hopkins Women's Health Podcast, A Woman's Journey, Insights That Matter. I'm Kelly Gear-Ripken, and I invite you to listen to Johns Hopkins specialists discuss the latest topics in women's health. Now here's your host, Lily Shockney.
Hi, this is Lily Shockney from A Woman's Journey at Johns Hopkins, and this is our podcast, Healthy Insights That Matter. October is National Breast Cancer Awareness Month, and in honor of Breast Cancer Awareness Month, we are discussing ductal carcinoma in situ, also known as DCIS, a particular type of breast cancer, which accounts for about 20% of all breast cancers diagnosed. I am joined today by Sibley Memorial Hospital's breast surgeon, Dr. Han Tam Tran, whose clinical research focuses on identifying patients who have DCIS and just how should we go about managing it. So welcome, Dr. Tran, and thank you so much for joining me today.
Thank you so much, Lily. It's a pleasure for me to be here today.
I think we probably should start with explaining what is DCIS, what is ductal carcinoma in situ?
Ductal carcinoma in situ, by definition, what we see on pathology is the milk ducts that carry the milk out to the nipple. Within those milk ducts, there could be abnormal cells that grow. When the abnormal cells grow by a few layers, that's what we use to define ductal carcinoma in situ. The thing with ductal carcinoma in situ is that it has the word carcinoma in it. And I believe that's a misnomer because what happens is when we talk about traditional cancer, usually what that means is these abnormal cells have broken through the walls and it has the ability to move outside of where that tissue is and throughout the body. And the key word there is potential, right? Invasive cancer has the potential to move outside of where the space is. Ductal carcinoma in situ are abnormal cells, but they're still contained within the walls of the milk ducts. Therefore, technically, it's not considered a true invasive cancer. And we consider this as a stage 0 or a precursor to cancer. The key word here is ductal carcinoma in situ could be a precursor to invasive cancer. And that's why we talk about doing treatment for it.
There's also another term that I'm sure quite a few of our listeners have heard and maybe even have received as a diagnosis themselves, which is lobular carcinoma in situ, LCIS, which is not cancer, and yet it also has that carcinoma word in it. Can you just give us a little bit of a rundown as to what it is and what it means if someone does have a biopsy that comes back with LCIS?
Once again, another misnomer. LCIS, lobular carcinoma in situ, is just some cell growth that originates from another part of the milk system. And what we know is that if we leave those cells alone, they're not a precursor to invasive cancer. They don't develop into invasive cancer over time. And because they don't have that potential, it's not a requirement for us to chase after them or to do surgery for them. And a lot of times we just leave it alone. Versus ductal carcinoma in situ, some of those are precursor to invasive cancer. And because of that potential, that's when we usually talk about doing an intervention of some sort, preventing invasive cancer in the future.
When someone's coming in for a screening mammogram, no lumps, no bumps, no troubles. She's been coming in every year since she turned 40. And on this mammogram, she's told, gee, we see something. We want to get some additional imaging done. It looks like you might have a cluster of microcalcifications. Can you talk a little bit about that and what that could mean?
Mammograms really, what they do is they're looking at our breast tissue. And a lot of times our breast tissue is fatty tissue and it shows up as black. Calcifications are like crystals. Kind of think of like salt crystals, and then it could be sprinkled along that black background. There are many different types of calcifications. It could be a single dot of calcification, which are always benign. But when calcifications form and they are of different sizes, or if they're bunched up together, then it tends to signify that there could be something going on or some abnormal growth occurring. And usually when that happens, what we'd like to do is get a little biopsy, meaning get a little piece of tissue. And the radiologists are able to do that with the core biopsy. They take out some tissue and just a sample and see what's going on a microscopic level. And based on what the pathologist sees, that's where we get a diagnosis. But calcifications could be many reasons. It could be breastfeeding, it could be trauma, it could be a lot of benign processes, and calcifications can also signify DCIS.
I have had several patients ask me if taking in too much calcium would cause microcalcifications, and I've told them no, but they had read this somewhere on the internet. I said, you can find anything on the internet, and most of it is not correct, unfortunately. So when we're looking at DCIS, this is the earliest that we could potentially find trouble and be able to head things off at the pass before we would be looking at invasive disease, which would start with stage 1 and go all the way up to stage 4. With DCIS, so for this year, 2023, it's projected that there will be somewhere between 55 and 60,000 women diagnosed with DCIS, but there's a whole lot more that are diagnosed with invasive disease, right? Invasive ductal carcinoma, invasive lobular carcinoma, and then there's some others that are more rare that happen. When we're looking at the 1 in 8 women, sometime in their lifetime span, getting breast cancer, it isn't always the invasive kind. It may be this more, I'm going to say simplistic, the one that doesn't make as much mischief. If we see on a mammogram a lot of microcalcifications, does this increase the possibility that there might be some invasive cells buried in there somewhere?
It's possible. And the reason for that is when we look at a mammogram, I always like this analogy to tell my patients. Mammograms, they're kind of like helicopters. They're going around, they're trying to scan and see something that are abnormal. When you have like an army of bad soldiers or bad cells, if it's big enough, the helicopter can pick out that army. But if they're really small or there's only 1 or 2, they can just hide under a tree and the helicopter's not going to pick it up. So that's mammograms. That's all imaging. That's our limitation. We can't see microscopic cells with imaging. So when you have widespread calcifications and you only do a biopsy of one spot, you know for sure what that one spot shows, but you don't know what the other areas could be. And so there could be at another spot invasive cancers that's starting. That's why we need tissue for diagnosis.
If someone is diagnosed with DCIS, what is the next step?
Usually what we recommend is they go to see a breast surgeon at a comprehensive breast center. When you're there, the breast surgeon can sit down with you and go through the details and explain to you what ductal carcinoma in situ is and what are the different treatment options that we have nowadays.
Are there situations that if a patient said, I don't want to do anything, I just want to wait and get my mammogram in 12 months, see if there's any change or not, what response would you give to that kind of a question?
Before we can touch upon that, I'd like to bring up a concept that a lot of patients may find upon doing their research about DCIS. The concept of overtreatment of DCIS. Like I said, DCIS is a precursor to invasive cancer, but not all DCIS will eventually become invasive cancer. And we know that through longitudinal studies and retrospective studies. So we do try to look at characteristics of the DCIS that would help us gauge whether or not this is a low, slower growing versus a more aggressive form that may have future potential to become invasive cancer. I would review those characteristics with this patient and see if she qualifies for an observation approach. And for you to qualify for that approach, you would want to have some ductal carcinoma in situ that is a slower, lower grade, or it's hormone positive. It means it feeds off of estrogen. And I think it really depends on the extent of this area of abnormality or the extent of the DCIS. If you have less than a centimeter worth of area of abnormality, then you meet those low risk criteria, then it's reasonable to consider observation. But if you have a very extensive area of calcifications and it's all throughout your breast and we only have one biopsy here, I would be worried that there could be something else lingering around. And I don't think that would be a good candidate for observation. Those would be the things I would think of. And then the other thing to consider too is a patient's age, what medical comorbidities they may have, and what family history they have. If they have a strong family history of breast cancers and a lot of early deaths due to breast cancers, then I would not consider observation, and I would strongly recommend doing excision for that. We want to prevent any invasive cancer that could occur in the future.
Could a woman have any symptoms that she would notice if she had DCIS in her breast?
For the most part, no. DCIS is usually found on mammograms, and it's screening mammograms because we're talking about abnormal cells that are still contained within the walls of the ducts. So most of the time, no. There are, on some occasions, you may notice some bloody nipple discharge that could be related to ductal carcinoma in situ. And then rarely, maybe a mass, and that's because the ductal carcinoma in situ is found as an incidental finding next to something else. That would be a rare chance, but for the most part, patients are asymptomatic.
What are risk factors associated with DCIS?
Risk factors for DCIS is similar to any risk factor for patients with higher risk of breast cancer development. And that comes back to whether or not you have a family history of breast cancer. Usually we say any first degree or second degree relatives with breast cancer, anybody who has family with breast cancer at a young age, meaning less than 40 years old. We see ductal carcinoma in situ in patients who are on hormone replacement therapy for an extended period of time, or any patients who have late menopause or never had any children before. Those are the typical risk factors for any breast cancer development.
Thank you. More and more, we're seeing women having breast MRIs to be able to do a deeper dive, shall we say, in looking at the breast tissue. In particular, if she has very dense breasts, which are not going to look as black in that background as we wish. They'll have some gray areas and some white areas, and in there somewhere is also an invasive tumor. But we're not always able to see DCIS on an MRI. And of course, people say it finds anything. And I'm like, well, no, don't say that. It doesn't necessarily find anything and everything. So can you educate us about that?
Each imaging modality specializes in looking at the breast tissue from a different perspective. That's how I like to say it. Mammograms are good at finding structural findings. They see something that changes, like a mass or calcifications, like those salt granules that I referred to earlier. MRIs tend to work more so in the lines of looking at breast activity. Because of the way the MRI is looking at the breast tissue, it doesn't always pick up calcifications, and it actually doesn't pick up calcifications very well. So if it doesn't pick up calcifications well, sometimes it can't pick up this DCIS. We do encourage patients that if you're doing screening, that you do a mammogram and you can supplement with an MRI, but don't do an MRI alone. It's not going to be enough.
Mm-hmm. So is there anything that women can do to prevent developing DCIS?
There is. We talk about prevention of breast cancer, and that means that you can take a medication and it's taken once a day for about 5 years. It's called tamoxifen if you're premenopausal, or an aromatase inhibitor if you're postmenopausal. The thing is, with those medications, yes, it helps and it can prevent future breast cancer development, but there are side effects, and the side effects should not be taken lightly. So if you have a strong family history of breast cancer, or if you have risk factors found in your breast tissue that suggest that you will be at a higher risk of future breast cancer development, we would talk about considering this medication, but I would not recommend this medication to anybody with low risk factors, because the benefit of this medication does not outweigh its risk. The risk is too high. It is a discussion that you can have with your breast surgeon or medical oncologist. But once again, it's only for patients who are at a higher risk of breast cancer development. And higher risk is defined as a lifetime risk of 20% or more. Most patients without any family history only have like a 12% lifetime risk of breast cancer development.
When we're looking at methods of prevention, there are women that are listening to us right now that have been taking hormone replacement therapy for quite a while, as in multiple years. There was some research done specifically on this quite a while ago now, saying that gynecologists and PCP should not be so quick to hand a patient a prescription for hormone replacement therapy because this will bump up her risk of developing breast cancer. So for all you gals out there, if you are on HRT, it is intended to be for short-term use, as in 6 months or less, even though it might make your skin look great and your mood improve and all that good stuff. It is a risk factor. And some literature has even referred to it as a carcinogen, which is a pretty serious word to use. We also recommend watching alcohol intake as another way of reducing, not just for DCIS, but for any type of breast cancer. I think that we need to educate girls as they're going off to college. When they head off to college, they're no longer living at home. They're responsible for their health. They're adopting potentially bad lifestyle behaviors like alcohol, and they're usually gaining 10 to 12 pounds that freshman year. We don't want extra body fat that can store breast cancer either. I'm an avid believer and promoter of a program that I developed at Hopkins in 2001 called a Breastival, promoting breast health among young women to make it entertaining to learn and also take the fear out of it. So when she's doing a breast self-exam each month, she's not scared to death. She treats it like she does brushing her teeth. I don't think anybody goes, oh my God, I got to brush my teeth this morning. It's a habit. And we certainly do want people to get into the habit of paying attention to their breast health and taking the right measures to reduce the possibility of developing any form of breast cancer in the future. We're looking at treatment options for DCIS, which we know might have some hidden invasive disease in there potentially. What are the treatment options? And let's begin looking from a surgery perspective.
The goal of surgery in treatment of DCIS is really to take out these cells that could be precursor to invasive cancer. So you take them out and reduce your risk of invasive cancer in the future. And the second goal is to make sure that you check the tissue to make sure that it's all just ductal carcinoma in situ, because sometimes it could also have some invasive cancer right next to it that we just don't know, because once again, we haven't sampled it all. So doing surgery achieves that purpose. Generally, the two options that we have from a surgical approach are either a lumpectomy, which is just removing the area of abnormality and leaving the rest of the breast tissue alone, or a mastectomy, removing most of the breast tissue and just leaving the skin. Usually when we take out the area of abnormality alone via a lumpectomy, every now and then we do worry that maybe there are some abnormal cells a little bit further away from where the lumpectomy occurred. If that were the case, we won't see it yet because it's not big enough for us to see. And so you may have a potential higher risk of future recurrence in that breast. And to reduce that recurrence, we usually recommend doing radiation after the lumpectomy. And what radiation does is it is like high energy that shocks the cells, and it prevents them from becoming or forming that cancer in the future. So usually lumpectomy, we say follow it with radiation. When you do a mastectomy already, you're removing the majority of the breast tissue. And so the chances of recurrence is still very low, but it's still there. And then that's the thing. It's also a misconception. A lot of patients say, well, if I have a mastectomy, I'm good. All the breast tissue is gone. I'm never going to have a recurrence. It's never going to come back. Not true. With the mastectomy, you still have anywhere from like a 2 to 5% chance of a recurrence that can occur in the breast. The analogy that I use is this. Think of your breast as a pie. The pie filling is your breast tissue and the pie crust is your skin. Doing a mastectomy, we're scooping out all of the filling, but we're not going to be able to go after every single piece of pie filling that's touching that crust. And as long as you have filling that's touching the crust, there's breast cells that are there. That could always be a chance for a recurrence in the future.
For women that have mastectomy, many choose to do some form of breast reconstruction. does that increase the risk of having a local recurrence of DCIS or invasive disease?
From what the data suggests, no. Doing a mastectomy with reconstruction does not increase your risk of future breast cancer recurrence.
What is a woman's risk of developing breast cancer in her other healthy breast?
With DCIS diagnosis, we generally give a rate of 0.5% per year for the amount of years you have left in your natural lifespan. So you're 60 years old and we're expecting you to live to 80, then maybe about a 10% risk in that 20 years that you have left.
And we need to encourage women to recognize that that means 90% are not going to revisit this. There is that tendency to look at the glass half empty instead of half full. At least that certainly has been my experience in taking care of patients. There's been some debate as to whether or not we're actually over-treating DCIS. Can you elaborate a bit about that debate and your personal thoughts on that?
Sure. Yeah, it's a great debate. What researchers are noticing is that sometimes not all ductal carcinoma in situ will become invasive cancer in the future. And if the whole purpose of doing surgery and radiation is to prevent invasive cancer, but if the majority of these DCIS will never become invasive cancer, it comes the question, do we really need to do anything about it? And I feel like that's a great question, because if it's never going to become invasive cancer in the future, then we could be overtreating a lot of patients and subjecting them to unnecessary surgery or side effects of radiation. So I do know that there is a trial that was started here in the US called the COMET trial, COMET. And what it does is it looks at those low risk DCIS, once again, those features in those cells. And if they are low risk and we guess that their potential for developing invasive cancer is low, we allow patients to just do a medication and do post monitoring with mammograms in a more often sequence every 6 months. And we really follow them to see what really happens to these DCIS. Now, if we see ductal carcinoma in situ that are grade 3 or consider high grade, or if they have features that may suggest that there could be invasive cancer nearby, then I believe and I strongly recommend that we actually do something about it, because doing the surgery is going to remove these cancer cells. It gives us a better diagnosis into what's going on, and then it can prevent your future risk of breast cancer development.
That will be wonderful. The more that we can do to prevent treatments that may not be absolutely necessary, I think the better off everyone certainly will be. You had mentioned earlier about the importance of getting into the arms of physicians and other breast professionals at a comprehensive breast center, which certainly Johns Hopkins Medicine has several locations of those. One of the things that I think is of paramount importance is having the pathology slides re-reviewed at a comprehensive breast center, because we know that there are more general pathologists looking at breast tissue biopsy specimens than there are breast pathologists. And you really do want to have a breast pathologist. I may not want him to look at my gallbladder or something, because he hasn't looked at that for 40 years. But the accuracy of that pathologist in determining, is this DCIS? Is this invasive cells? Is this even something earlier than DCIS? Atypical duct hyperplasia really does set the stage for what someone is going to recommend be the treatment. For those of you out there that are going locally to your doctor that might be a general surgeon as well and not a breast surgical oncologist, please have your pathology slides re-reviewed at a comprehensive breast center before you have anything done to you, so that the accuracy of the diagnoses can be confirmed. There's nothing, in my opinion, worse than getting the pathology re-reviewed later, which I have had patients do, and find out that they didn't even have breast cancer, not even DCIS, which is very unfortunate. good news, but she's already had surgery and already had radiation. So that's the bad news part of it. So as I say, the patient may never meet that daggone pathologist, and yet they hold most of the cards when it comes to what are we going to be doing about this. I'll also say that we've talked about HRT and the stimulation that female hormones can have on breast cancer cells, including DCIS. That actually is a good prognostic factor to have if your cells are stimulated to grow by estrogen. Most people could think, oh my gosh, no, I don't want that. But it does tell us that this is a better behaved breast cancer, and we have a way to cut off its food supply of estrogen, taking that drug that Dr. Tran mentioned, tamoxifen, which we've been using for more than 60 years in the United States. A lot of people think that the hormonal therapy drugs that you see commercials for on television now are brand new, and that all of the hormonal therapy to treat breast cancer is brand new, and yet it's major old. I'll give you an anecdotal on tamoxifen. When I was in nursing school, which was more than 50 years ago, there was a study being done at that time. It was not one that I participated in, but I was offered to be in the study, where we had college students who were going to be taking tamoxifen for the purpose to see if it prevented pregnancy. It did not work. Girls got pregnant. So they went, well, this didn't work for that, so we won't use it like a birth control pill. But what they did find, and this obviously took a very long time, you have to longitudinally follow these women for a very long time, it did reduce their risk of getting breast cancer. And that's when it was like, oh, let's take a look at this a little bit more. So that's the funny and the unfunny of young women participating in that study, I guess, and then having to go home on break and say, I participated in a clinical trial, and that was a really good thing. And the bad news is I'm going to have a baby. So we aren't using it for that purpose, but it is an amazing drug, as are these other hormonal therapy drugs for treatment as well as for prevention. I'd like to say to Dr. Tran, I'm tickled to have the opportunity to talk with you today because we're both in the same arena, that arena of taking care of patients with breast cancer and doing research in this area too. There will be more than 300,000 women and about 2,000 men diagnosed in 2023 with breast cancer. And we know that these numbers are going to continue to go up because baby boomers are now in midlife and they've swelled the denominator, which in turn swells that numerator. So though we're still running at a ratio of 1 in 8 women over their lifetime, we still are going to see the actual raw number of individuals diagnosed continue to be on an increase. I am a 31-year breast cancer survivor diagnosed in my 30s. One of my best friends is a 50-year breast cancer survivor this year, diagnosed at the age of 20. So there are lots and lots of us that are surviving and thriving. The surgeries that are done today look a whole lot better than what we did 50 years ago and 60 years ago, that we didn't have the sophisticated tools and methods that we do today to be able to have the breast still look good after a lumpectomy, but also have that breast that we did a mastectomy on potentially be a fooler. Because there are many, many, many women who have had skin-sparing, nipple and areola-sparing mastectomy with reconstruction. And I would challenge you to figure out which is the healthy, natural breast and which one did we remove and replace it with something that was healthy. We have come a long, long way. We still have a long way to go, though. There will be 43,000 women diagnosed this year with metastatic breast cancer, and they eventually will lose their life to this disease. So I encourage you to be getting your mammograms annually, starting at the age of 40. If you have a significant family history, say your sister and your mom had breast cancer and they were diagnosed premenopausally, that would put you in a higher risk group, and you may need to be getting some form of breast imaging under the age of 40. since I was in my 30s, diagnosed my first time. My daughter is in her mid-40s. She started breast imaging actually in her late 20s. My hope is that all of the incredible research that Johns Hopkins does and other large academic institutions also do will prevent her from wearing my bra one day, and will also prevent my granddaughter, who's 14 and a half, from wearing my bra. If you live in the DC area, Northern Virginia, Maryland, or Pennsylvania, if you do, there is still time to join the Johns Hopkins Medicine A Woman's Journey event that brings together hundreds of women to learn more about important women's health topics, including breast cancer. To register for A Woman's Journey, next in-person event on Saturday, November 18th at the Marriott Waterfront Hotel, dedicate a morning to yourself and to your family. Enjoy a heart-healthy buffet breakfast, our inspiring keynote speaker, and 3 of 6 compelling presentations about medical advances will be discussed that day. To receive information about this event and other women's health content, please visit the A Woman's Journey website at hopkinsmedicine.org/A Woman's Journey to sign up for our monthly e-letter, read about upcoming podcasts like this one and other programs, and to sign up for our upcoming free Conversations That Matter webcasts. Thank you for listening, and I hope you will join us next month for another educational and information podcast featuring another Johns Hopkins medicine expert like Dr. Tran. And Dr. Tran, again, thank you for joining me today.
Thank you so much, Lily.
Thank you for listening to A Woman's Journey podcast. Join me, Kelly Gear-Ripken, your host, Lily Shockney, and a variety of Johns Hopkins experts on the first Thursday of each month to learn about medical advances in women's health. A Woman's Journey is grateful for the unrestricted educational grants from HRH Foundation that supports our podcast series, Insights That Matter. For more information about A Woman's Journey's virtual programs occurring throughout the year and our monthly webcasts and podcasts, visit our website, hopkinsmedicine.org/A Woman's Journey. Like us on Facebook and Twitter, and visit our website at hopkinsmedicine.org/A Woman's Journey. Until next time, stay well.